So IFR, or instantaneous rate-free ratio, is what we call a resting index. A resting index means that we're not using any agent to cause hyperemia, such as adenosine that's commonly used for FFR. So IFR, we use that as a wire-based technology. We put the wire distal to a lesion and then interrogate whether that lesion is ischemic, in other words, causes symptoms, and whether we should revascularize that patient or not. Well, I would say the main benefit for the patient in itself is the fact that not giving adenosine means not having any of the side effects of adenosine. Normally you get a lot of chest pain or chest discomfort or dyspnea from it, but sometimes you even get bradycardia, tachycardia, and other actually life-threatening complications, although they're rare. So from our previous studies, we've shown that approximately 2/3 of patients have symptoms of adenosine administration. So that is one benefit for the patient in itself. The other benefit, I think, for the cath lab staff, for the physician, is the fact that iFR is instantaneous, as it says in the word. You immediately get a good measurements that you can use. You don't have to wait for hyperemia. And the third one, which may not be so very obvious, is the fact that in more diffusely diseased vessels, such as the LAD, you can do a pullback. And this pullback, we found now that we can accurately detect which lesion is causing ischemia. And this is actually something that's very important and might be a further advantage compared to, for instance, FFR. So we've previously done what we called outcome studies, iFR Swedeheart defined flare studies, showing that we had an excellent one-year outcome, which was non-inferior, in other words, similar to FFR. And our own analysis from the 5-year data from iFR Swedeheart showed a similar finding, non-inferiority. However, there was a spurious increase in mortality among the treated patients in defined flare, which really didn't make any sense to us because we didn't really see any signal of more events when it comes to MI and revascularization. So essentially what we did is that we went back to our Swedish National Quality Registry, Swedeheart, and looked at all patients who have been interrogated with either IFR or FFR, and looked at them, followed them up for 5 years, which is something we can do in our registry because in Sweden we have personal identifiers, personal numbers, which means we can track every single patient as long as we want to. So what we found is that among 48,887 patients, there was no difference between IFR and FFR in terms of outcome. And we looked at MACE in itself, as the composite death, MI, and revascularization, no difference at all. We looked at death, MI, and revascularization independently, and we couldn't really find any signal at all. And then also, because of this increase we found in defined flare, we looked at the deferred and the revascularized patients, see if we can find any difference, but really, it was neutral all over. So in this much larger analysis, we really couldn't really verify the finding from defined flare at all.
Why do you think these findings are important to have them now here at this moment? There was some debate about mortality rates.
Yeah, I mean, defined flare mortality rates, since it's a randomized study, albeit much smaller than the non-randomized observational data we have now, sometimes you can have these play of chance that causes an increase in mortality, and I completely understand that if you do get an increase in mortality, you cannot explain this is a cause for concern. So this is really essentially why we went back to do this large registry analysis to confirm that this was in fact a play of chance. So this is very important. And what it tells us that you can use either IFR or FFR to safely guide your revascularizations. So I think we can kind of put an end to that debate that one index is better than the other in terms of outcome, but really has to do with your preference.